Good morning, everyone. My name is Sahar Hesham, and I am board certified infectious disease clinical pharmacist licensed in the UEA with the master in the clinical pharmacy. Today, I will present an update on the 2025 IDSA guidelines for the management for complicated urinary tract infection. These guidelines should be used in conjugation with 2010 IDSA guidelines for the treatment and management for the uncomplicated UTI. Also, we should use 2019 guidelines for the management for asymptomatic bacteriuria because these guidelines only address the complicated UTI. In this presentation, we will cover the updated classification for the UTI, the selection for the empirical and definitive antibiotic therapy, also when to the timing for the transition from IV to oral antibiotics, and the recommended duration treatment for the complicated UTI. The aim is to provide a practical guidance to optimize the patient outcome while minimizing the antimicrobial resistance. In this slide, we will focus on the changes in the definition for uncomplicated and complicated urinary tract infection. So, in the previous guidelines, the uncomplicated UTI referred to the infection confined to the bladder. So, it's called usually uncomplicated cystitis in women of a childbearing age from 15 to 45 years who are not pregnant, not diabetic, and has no any signs for pyelonephritis or any other urological abnormalities. Any other case rather than these criteria has been considered as a complicated UTI. But in the new classification, we broaden the scope of the uncomplicated UTI to include men as well as the patients presented with diabetes or certain neurological abnormalities. However, if these patients develop any fever, any signs for systemic symptoms, any bacteremic UTI or urosepsis signs, or any symptoms suggesting pyelonephritis, or have any indwelling catheter, are being suspected to have complicated urinary tract infection and being classified to having a complicated urinary tract infection. It is a very important note to note that these recommendations do not apply to the patient with prostatitis or those who are presented with neurogenic bladder or those are presenting with the urinary obstruction or urinary retention with underlying condition. Also, it is very important to know that this recommendation is only intended to guide therapy, not for the diagnosis. Okay, so this recommendation is only guide us for the treatment options. When selecting empirical therapy for complicated UTI, you should proceed in four-step approach. Four-step approach will help us to guide the treatment decision. So the step number one is how to assess the severity of the patient. The patient has been diagnosed to be complicated UTI, then you should assess at which stage or at which severity the patient is being placed. So to determine whether the patient has a sepsis or if so, whether it is compliant with the septic shock or not. Also assess if the patient, even without sepsis, required to be managed with IV route therapy or IV antibiotics. So this patient should be hospitalized, or it can be safely managed as an outpatient with oral treatment option. Here, there is a very important update. In the previous guidelines, the urosepsis or the patient presenting with sepsis due to UTI, they should be treated with a combination with carbapenems, because this patient should be considered to have a risk for ESBL producing organism plus anti-MRSA coverage. But in this new guidelines, the anti-MRSA is not being used routinely, and this is one of the most important updates in these guidelines. We only suggest or we only recommend the use for anti-MRSA when the patient has a documented prior MRSA colonization in the urine. The recommended empiric agent may include even third generation or fourth generation cephalosporin, and as you know, there is a lot of members in the third generation cephalosporin that does not have any pseudomonal activity. Okay, so you can use or treat your patient with sepsis with an antibiotic with a narrow spectrum does not have a Pseudomonas activity. Carbapenems, and even the carbapenems, you can use it, okay? Or you can use piperacillin, tazobactam, or even fluoroquinolones. So to depend or not whether or to choose between these options, you will go through step number 2 and step number 3, which is the patient risk factor and the presence of resistant uropathogen. Okay. Okay. Let's go in the patient. If the patient are presented without sepsis, but they should be treated with the IV route of therapy, okay, and the patient does not have any risk factor for resistant, the options will be cephalosporin, piperacillin, tazobactam, or fluoroquinolones. Without carbapenems, you should not consider carbapenems if the patient does not have sepsis, except if the patient has risk factor of resistance. And this is in the footnotes, and you should consider it because it is not present at the table, but it's mentioned in the rationale and in the background. So you can use carbapenems, but take care, you should not use carbapenems except if the patient has resistance. Okay. Regarding the oral options, when appropriate, include trimethoprim sulfamethoxazole or even the fluoroquinolones. The above recommendations are preferred option, but if these preferred agents are contraindicated or they are not available, so you should use the alternative agent, which is older or the newer aminoglycosides, or even using the newer beta-lactam, beta-lactamase inhibitor options. Okay, this is for those who need the IV route, and those who are needing the oral route, you can use cephalosporins or amoxicillin clavulanate. As you see, that fluoroquinolone and trimethoprim is still, they are the preferred option and as an oral option, and the amoxicillin clavulanate and oral cephalosporin are used as an alternative. And this is also one of the recommendation or the new recommendation when you choose the oral option or the best oral option available. If you have the two options, the fluoroquinolone and the trimethoprim sulfamethoxazole will be the better option due to higher efficacy, higher urinary concentration than oral cephalosporins and amoxicillin clavulanate. Also, you should note that oral fosfomycin and nitrofurantoin are generally not appropriate choice for the complicated UTI. Why they are not appropriate? Because they does not achieve an adequate level in the renal parenchyma or in the blood. The recommended cephalosporins, as I mentioned in the from 3 or 4 minutes ago, that the cefotax and the ceftriaxone, which are agents that does not have antidomonal activity, can be an option in the sepsis, or even the ceftazidime or cefepime. The fluoroquinolone that can be used is cipro and levofloxacin, and also as we know that moxifloxacin cannot be used for the urinary tract infection because it does not achieve adequate concentration in the urinary tissue or the renal tissue or the bladder tissue. All carbapenems can be used, even l-ertapenem, which does not have any antidomonal activity. And after we finish the fourth step, the assessing the severity. Okay, if the patient is being assessed as being or as having sepsis or sepsis with shock, then you can proceed on step number 4, which is the involving the antibiogram if it is available. When selecting an empirical antimicrobials for complicated UTI, the risk factor of resistance changes from the previous guidelines. The new risk factors, or the even focused on the risk factor that include that avoiding any antibiotics to which the pathogen has been resistant in the previous culture. So if the patient has been admitted, you should make a reconciliation and you should go back and see all the urine cultures for this patient, okay, especially in the past 3 to 6 months, and consider if there is a resistance pattern, and you should consider this resistant pattern when you take a new decision for the empirical therapy. If you have a lot of urine culture, you should focus on the most recent urine culture rather than the older ones. Also, if the patient has been exposed in the past year for the fluoroquinolones, you should avoid using fluoroquinolones. The third one is use considering broad spectrum agent okay, broader for pathogens that are non-enterobacteriaceae, such as Pseudomonas, Enterococci, and even MRSA, only if the sepsis are being diagnosed, okay, and the diagnosis is not clear for it's only for complicated urinary tract infection, or if the diagnosis for the urinary complicated urinary tract infection is unclear, or when the pathogens are likely. Yani you have even past urine culture that shows Pseudomonas aeruginosa or Enterococci or methicillin resistant Staph aureus. So if you have a document, or if you have previous culture that show those organisms, so you can consider the agents that covering these or antimicrobial that covering these agents. But if you don't have any evidence, or you are being sure that the sepsis is from complicated UTI, you should only consider the enterobacteriaceae as E. coli, as Klebsiella, or Proteus are being the most common uropathogens that causes UTI. We must also consider the patient risk factor to avoid undesirable outcomes and to refining the options that are available, okay? To choose from different options. This includes checking the allergies for the or allergic reaction for the patient, if the patient has any contraindication, the drug-drug interactions, okay, to prevent any adverse effect. In septic patient, the empirical therapy should also be tailored using hospital antibiogram, as I will discuss later in this lecture, to improve coverage and effectiveness. So as I mentioned in the previous slide, it is important to consider antibiogram when tailoring empirical antibiotic therapy only in the septic patients, okay, as a step number 4 in the 4-step approach. The antibiogram should be relevant, okay, so you should not only use the antibiogram or the cumulative antibiogram or something like that. You should focus on the antibiogram, or if you will take a decision by using antibiogram, this antibiogram should have a special characteristics which should be relevant to the specific institution, up to date, and should include urine culture from the patient with similar characteristic collected within the previous 12 months. These are the criteria for the appropriate relevant antibiogram that you should take it in your consideration in order to take this antibiogram in your mind when you choose the empirical antibiotic. When using the antibiogram, it's critical to select the agent with at least 80% susceptibility if the patient has sepsis without shock. Okay, and if the patient is shocked or presented with septic shock, the recommended agent should be single agent and at least 90% susceptibility. So in UTI, it's not recommended to use combination therapy. Okay, it's most appropriate to use single agent. But the issue is that you try to choose the agent that susceptibility is high in case of shock, in order to be confident enough that this agent will be effective, and even after the culture, most probably this agent will be sensitive. Okay, so the person susceptibility for the agent used in septic shock susceptibility must be higher than those presented only with sepsis. Again, when you choose antibiotic, you should also determine the accurate dosing, and the accurate dosing is very critical. Underdosing can leading to resistance and even the treatment failure. Okay, while overdosing will increase risk for toxicity without any added benefit. So dosing should always be adjusted based on the renal function, patient-specific pharmacokinetic. Please note in this table. So the dosing should always be adjusted based on the renal function and the patient-specific pharmacokinetics. Please note that the phosphomycin here is being added at the table for the agent that can be used for treatment of complicated and management of complicated UTI. But this phosphomycin is only used in an IV or intravenous route, because the oral route is not effective. Regarding the cephalosporin use, it's usually used in 1 to 2 grams. The higher doses, 2 grams, generally used for cases of urosepsis, while the lower doses, which is 1 gram, typically used for UTI not associated with sepsis. Once the pathogen identification and susceptibility are being available, we should make narrowing to the most effective and the least broad spectrum agent. This approach supports the antimicrobial stewardship concepts, which reduces the risk for resistance development by the use of narrower spectrum antimicrobial. The de-escalation is less practical for the use of complicated or for the use of the in cases of complicated UTI managed as outpatient, because we already as an outpatient setting we use oral and we use the narrow spectrum antibiotics. The transition from the IV to oral therapy is recommended if the patient meets the following criteria. So the patient should be afebrile, hemodynamically stable, and any urinary obstruction has been relieved, so this patient has a source control. This step will support the patient to be discharged early and improve the patient comfort and reduce the healthcare cost. However, this recommendation cannot be fully applied to the patient with the following criteria: the patient who are in sepsis or septic shock, the patient who has urinary catheter, the patient who are severely immunocompromised or has severe renal insufficiency or have functional or anatomical urinary tract abnormality. So the decision whether or not to shift from IV to oral for these patients, the decision should be individualized and depending on the clinical response and the patient situation. This slide will support the previous slide where the patient who has gram-negative bacteremia together with the complicated UTI, so the patient who has urosepsis, it's very low certainty and very low evidence suggesting that this patient can be shifted from IV to oral, and if this patient need to be shifted from IV to oral, should be afebrile, hemodynamically stable, and achieved source control, and this patient become not in sepsis anymore. So this slide, I will talk about the oral options and the best options to be given to the patient in complicated UTI. As we mentioned that the choice for the antibiotic will depend on many factors like susceptibility results, patient comorbidities, and even the drug pharmacokinetics. So according to the guidelines, the most preferred agents are the fluoroquinolone and trimethoprim sulfamethoxazole because they have a better efficacy due to high bioavailability and they has been concentrated in urine, so they are the preferred agent. So we usually go through the oral beta lactam if there is if the susceptibility for this agent has been documented and the use for the fluoroquinolone and trimethoprim are not feasible. So usually the beta lactams or the oral beta lactam, whether the cephalosporins or even the amoxicillin clavurinate, we should start it or we should give it to the patient if the another agents are not feasible. In case of resistant bacteria where there is no oral suitable option, like in case of resistance, the duration of therapy may be needed to be completed using the parenteral antibiotics. In this slide, I will talk about the duration of the antibiotic for complicated UTI, and the duration is very, very important factor, which will decide whether or not the patient will be fine or if we stop the antibiotic before the recommended period, this will induce resistance and also will let the patient get a relapsed or recurrent infection. So the duration is calculated. So one of the most important issues you must be addressed that the duration is calculated from the first day of the effective antibiotic coverage, not from the start of the empiric therapy, because you can start empirical therapy and this empirical therapy is not fitting the patient and it is not suitable for the patient. So the starting or the counting for the duration should be from the first day of effective antibiotics. Okay, the treatment duration depending on the patient condition and the causative organism and the clinical response. Whenever possible, the shortest effective duration are preferred to help to reduce resistance. But if the patient show rapid clinical response or rapid clinical improvement, the total duration should be 7 days as mentioned in this figure. Okay, you should switch from IV to oral and the total treatment duration should be 7 days. Okay, but if the patient does not show a clinical response and the patient does not have improved rapidly, you should reassess whether the causative organism is susceptible to the prescribed antibiotic, which is called drug bug mismatch, that the drug is not fully susceptible to the microorganism, and also if there is any unresolved source for infection whenever the diagnosis is correct, because maybe the diagnosis is not correct or the patient has any other undetectable source for infection. So you should reassess all these factors if the patient is not clinically improved. Very important note that most study recommending shorter duration rather than longer duration, okay, and don't take into account certain patient groups. There is a certain patient groups is not mentioned clearly in the guidelines, such as those who has urinary catheters, sepsis, immunocompromisation, or those who have abscess, okay, or those even or those who have chronic kidney disease, bacterial prostatitis, or incomplete urinary obstruction, okay, or those who undergoing urological surgical procedure. Those patients or those subpopulation does not mention clearly in the guidelines. So the application or the duration should be individualized depending on the clinical response. So you will depend on the clinical response rather than you give a shorter duration of antibiotics. Finally, this is all about the updates from 2025 IDSA guidelines for the management of complicated UTI. The guidelines mainly emphasize the individualized evidence-based management for complicated UTI, focusing on the choice for the most appropriate antibiotic, empirical antibiotic based on the four-step approach, the IV to oral switch transition, and the optimization for the treatment duration. So by applying these principles, we can improve the patient outcome and contribute to the fight against antimicrobial resistance. Thank you for your attention, and I am happy to answer any of your questions. Please post it to me on the LinkedIn or on the YouTube or the Facebook. You are more than welcome for your participation. Thank you and goodbye. See you in more and more lectures about infectious diseases. Good luck.